Hello, good morning, everyone. Good to see your faces again. Just a reminder, if you've not met me or haven't seen me, my name is Denise Travis, and I am the liaison for Lutheran Senior Services division that we call Home and Community-Based Services. And those are the line of services that come to someone's home, wherever that home is. So for you here, that's independent living. Our services extend to assisted living, the care center, and then also out in people's home outside of the LSS walls in the community. Those services consist of skilled home health. So if you need therapy or an RN nurse to come into your home after a hospital stay, a fall, weakness, a new diagnosis, those are those services that your insurance normally covers if the doctor prescribes it. We have private duty services, which I know we have a la carte here at your community here. So you might have seen our a la carte caregiver who just from anywhere from 15 minutes to an hour moves to different apartments to do, things that people need within that time frame. As well as private duty that's 3 or 4 hours or more if you need more time. We have hospice services, and that is your end-of-life comfort care when you've elected that you don't want to have any further treatment or hospitalizations for whatever disease process that's occurring, and you're just like, I want to be kept comfortable, have the best quality of life, and not do all the treatments and the hospitalizations. That's our hospice end-of-life comfort care. But today, we are here to talk about palliative care and what palliative care is, answer your questions, talk a little bit about how palliative care is different than hospice, because I know the two of them have been linked together for quite some time, and they are very different. I think that the kind of new age of healthcare, we're really focusing on advocating for ourselves, understanding our disease process, understanding the options that we have to take care of those comorbidities, and how we can all really work together with the various clinicians and specialists that are a part of your life as you understand kind of what's happening with your body and whatever specific disease or multiple diseases or illnesses that you may have. And that's kind of what palliative care kind of steps in and helps in some ways. I have brought today my fabulous nurse practitioner, Karen, and so she's going to be the one who's going to be leading initially the discussion about what palliative care is, kind of sharing some of her stories of ways that she's helped patients with palliative care, and then we'll try to answer your questions and kind of wrap up the understanding of palliative care as well. So thank you for your time, and I'll go ahead and turn it over to Karen.
Good morning. I'm Karen Schroeder. I'm a nurse practitioner. I'm the nurse practitioner with LSS Palliative Care. We started the program back in March, started seeing patients in April, and so this is a relatively new position for me, but I did come from a previous palliative care company, so I have about 3 years in palliative care, and I find it a very rewarding area to be in, and it's kind of a new area, and so it's kind of nice to be a part of that. So I know, kind of to piggyback off of what Denise said, that historically we kind of group palliative care and hospice together, but they're in actuality two different areas of medicine, and one I wanted to kind of differentiate one from the other, and then I'll tell you more about palliative care. So what palliative care is when you're starting to experience like a decline in health, and you're noticing that maybe you're losing weight, you're feeling a little weaker, you're not getting around like you used to, or maybe you're having more hospitalizations because of a chronic illness. And with palliative care, it's the added layer of support for you, someone that can come and help watch over you and to make sure that if there's anything additionally, any recommendations that we could, coordinate with your primary team, that's what we do. When you're on palliative care, the qualifications for the palliative care would be decline in health, maybe some recurring hospitalizations, And with that, you can still seek out active treatment at the hospital. You can still receive therapy services. You can get chemotherapy if you have a cancer. None of your treatments change. You continue to see your primary care as well as any of your specialists. So that's kind of what palliative is versus hospice, like Denise had kind of said. With hospice, that's when you're at a point in your life where you say, you know, I've done all this aggressive therapy and it's really not getting me anywhere. There's no cure for my condition and I just want to focus on quality of life. So hospice, the defining criteria for eligibility would be if there's an argument that you're in your last 6 months of life. That's when hospice is something that would be recommended, and something that if someone's ready for hospice and ready for that added TLC from the staff and the added help with baths and counseling for your family and for yourself, that's when hospice takes over, okay? So for palliative care, what we do is if someone's interested in palliative care, they would get a referral from their doctor. So talk to your primary care. They would send us a referral. We would reach out and we would get you set up for your first visit. Now, with palliative care, it is covered by insurance. And I'll show you later on why the insurance didn't used to cover palliative care. It was an out-of-pocket expense. But the palliative care professionals have proven to the insurance company how valuable the service is, to a point that now it is a covered benefit through your insurance. So it's billed per service, per visit, and there's no out-of-pocket expense for that. So I would come out and get you set up for palliative care. And in our visits, I will get your vital signs, do a full head-to-toe assessment on you. And what I'm doing is I'm looking for any things that could lead you to the hospital or that could cause you to have a decline in health, and trying to address those things with you by education, with your family as well, by kind of educating on the condition and how we can better manage the condition, as well as coordinating the care with your primary care team or any specialist. Now, at the visits, we do a very thorough review of systems. So I ask a lot of questions and I get a lot of information from you about how you're feeling. And any symptoms or any problems that you're expressing to me, I'm looking for ways that we can help address those things to keep you doing well in your natural, environment and keep you out of the hospital if at all possible. So that's kind of what my goal is. While I'm in the visits, we also touch on advanced care directives. If people don't have those in place, I'm not sure if everyone knows what those are, but that's the documentation that says if I can no longer speak for myself, this is who I want to make decisions for me, and these are the kind of the guidelines for what I would and wouldn't want under those circumstances. So I help people get those in place, as well as if you're one thing that I noticed that is a very common issue is that people have elected on their advanced care directives that they do not want to be resuscitated if their heart were to stop. So if they were clinically deceased, they wouldn't want chest compressions and the breathing tube and all that stuff. Well, in order for people to carry out those wishes, there's an extra form that is necessary to be filled out and signed by one of your clinicians. And it's actually an order that says do not do CPR in the event that someone's heart's not beating. That only would kick in if somebody, if you were clinically deceased. Everything else, that's EMS and paramedics and the staff here would continue to do everything as long as your heart were beating. So those are paperwork. Those are things that we talk about, like what your wishes are. We can make sure that all that paperwork is in place in case it was needed. We also talk about disease process and what to expect as your conditions kind of progress, so that you can make plans and make provisions of what that's going to look like and what the needs are going to be at that time, both for as far as your care goes. So those are the things we talk about, and we talk about options. Not every if you're given a new diagnosis, not every time would someone want aggressive therapy at that point. So then we talk about, we can do route A or route B. These are what our options are. So I think that's very important to kind of know what your options look like. Now, if I'm in your apartment and I notice that there's something going on, I will address those things right away, and then I call or email the primary care clinician and let them know what's going on, what the plan is, and kind of what we did, and kind of correspond with them as well. And so I think the main goal I have is to keep people doing well, keep people in the comforts of their home, minimize hospital admissions, and to be a source of knowledge and support for patients and families alike. Sometimes people have issues where they're maybe they want to go one way, with their care. Maybe they want to be comfortable, and their family keeps saying, Mom or Dad, you have to keep going. You can't just be comfortable. We want you to be here, for 20 more years. And those are conversations as well that we have with the families to help them to understand kind of where you are in your disease process, and kind of help to bring everybody onto the same page, and so that they're at a point where maybe they will honor your wishes and answer any questions and be that source of support for them as well. When I talked about, let's see, how do you page down here? It's not right. Yeah, it's weird. Wait, page down. Oh, there we go. Okay, when I talked about insurance and reasons why insurance has been quick to cover palliative after we established kind of a baseline for what we are and what we do, insurance has decided to cover because we've proven our worth here. As far as people when they get out of the hospital, when you're in the hospital for a certain condition, you are at very high risk of being re-hospitalized in those first 30 days after coming home from the hospital, whether it be from the same condition, or maybe you've experienced some weakness and you had a fall or something like that. So with the education and the care provided with the palliative care, it's a documented statistic that it decreases your hospital readmissions by 48%. For admissions, like an initial admission, admission rates are down 50%, and emergency room visits are down 35%, because, like I said before, when I come in, I'm kind of looking for reasons that would, cause complications with your health, and that would lead you to the emergency room. As far as hospitals and emergency room transfers from skilled nursing, 43%. And then, so there's just a total overall cost savings for the insurance company, and this is why they do identify and cover the palliative care as a benefit, because financially it makes sense for them, as well as anyone that's been in a hospital. When you get out, you do have a lot of problems to overcome as far as weakness or diarrhea, constipation, and those are things that you're trying to get back to to that normal baseline can be quite a challenge. So if we can keep people out of the hospital, that's our primary goal, so that we don't have to, address these things on the back end when you get out of the hospital. Are there any questions? Yes.
You talked about if you are clinically dead or demised. How, and so your heart's not beating. What's the duration? Assume you know when it quit beating. What's the duration of time that is called?
That it's called?
That you call it.
Oh,
dead,
you mean like?
Gone.
Well, technically, the moment the heart stops beating, you're clinically deceased. Oh, I'm sorry. Yes. So the question was, what length of time when your heart stops beating do you consider it like deceased or clinically deceased? And the answer to that is as soon as your heart stops beating. Now, if you do have a DNR in place, that would mean that people would just let you be and not engage in resuscitation. If if someone did find you and you were down and your heart was not beating, they would start trying to resuscitate you because you are clinically deceased. And then there's a certain period of time, and it's dependent, it's all variable across the board on how long people will work on you before they call the efforts, that they weren't able to revive you.
So that's a subjective call that you need to be specific about? How long somebody would try to revive you? If you want to be specific.
If you want to be specific, well, as far as the paperwork goes, either you do, there's nothing that says how long to be resuscitated. So you're either do not resuscitate, or if you are a resuscitate, then that's at the discretion of the team that's trying to revive you. So there's really no paperwork that you can put in place that says this is the amount of time I would like you to make efforts to revive me, and if there's no heartbeat at that point to stop efforts.
So your heart stops beating and it's all hands off, just stop. Don't do anything.
Yes.
Okay.
Yes. Yes.
Then this is just what I'm thinking now.
Sure.
Is a palliative nurse practitioner, such as yourself, basically an intermediary between the patient and their physician, their primary care physician?
Yes, kind of. Yes, that's a good way to kind of wrap it up. It's kind of like an added layer of support, and I consider myself, on the patients that I see, I'm part of the care team, so I do update the primary cares and the specialists as needed. Now, I don't after every visit, but if there's some kind of change, or I've made some kind of change in the treatment plan, then that's when those updates are being made. Or if someone's starting to decline, then those are the conversations that I have with the primary care and the specialist.
Into hospice also.
Yes, and that's the other thing too. So once you qualify for palliative care, you can, according to Medicare guidelines, you can stay on palliative care indefinitely. So you're allowed to stay on until you decide, one, maybe you don't want the palliative care, or until you're ready for hospice. And then when I note that you're having a decline in health and that you would meet hospice criteria, those are the conversations that we would have as well, because I've seen hospice firsthand in my personal life with my parents as well as professionally, and I really have a great respect for that discipline, and I think they bring a lot of benefit to the family just as much as the patient. And there's research that shows that the longer someone is on hospice before passing away, the better their quality of life is. So that's why when I'm in, if I notice that someone would meet hospice criteria and they're declining, we're having that conversation. Now, sometimes people say, no, I'm not ready for that, and that's okay. But to know that I've given you all of your options, and it's up to you to weigh those things out. And then maybe, in 3 weeks you decide, hey, I think I want to do that because I'm getting worse, or whatever the case is, having those conversations. So I think it's super important. Personally, I tell my kids all the time, if anyone ever says hospice to you, you sign on the line, because I want it as long as I can have it, because it is so enriching to the families as well as to the patients. Yes?
Are there other things besides the heart stopping that people put into their living will or whatever?
There are other things except for heart stopping that you can put into your living will. And yes, there's a lot of, the actual advanced care directives is a pretty long statement, and it goes through a lot of things. If you don't have one, it's a really helpful document to have on file, and it pretty much says if there's no chance for recovery, would you want tube feedings to keep you alive? Would you want to be on a mechanical ventilator that's going to be breathing for you? Would you want dialysis? It goes line by line through all the different interventions that could possibly be recommended, and it helps your family to guide your care so that there's not the guilt, that they wouldn't have that guilt for making decisions for you because they didn't know what you would want. This really clarifies it all to make sure that your wishes are honored, as well as to kind of take that guilt off of your family.
And I would say that it's also important for those documents as much as possible to come with conversation with your family. It's this thing that we don't want to talk about. We all know that we're not going to live forever. We have no idea when that's going to be, but we don't want to talk about it. We don't want to address it. We don't want to think about it. We want to live forever. But we know it's going to happen, and we need to have more conversations. So you can fill out those documents, but also it helps your family just to talk to them. When I get to the point in life where I can no longer sit up, or you can't prop me up enough to be able to watch the Cardinals game and somewhat enjoy it, then I'm okay with you signing up for hospice and letting me go naturally, right? He put it into, his family knew how much of a Cardinals fan he was. He watched all the games, went to as many as possible. That was important to him. His family knows that. And so he put it into a perspective that they could understand, this is what quality of life is for me. And one of the things Karen keeps talking about is options, and a way that she usually terms that, but she hasn't yet today, is goal of care. That's one of the main focuses for her, is what is your goal of care? And like she said, she comes in and kind of asks certain questions, but part of that is calling you out on your own words, right? Because sometimes we say this is our goal of care, and then everything we're doing in our life is in direct opposition of what we say our goal of care is, right? You've met people like that, and sometimes that person is you, right? I want to work out. I want to be like about 40 pounds thinner than I am now. But the dinner that I had and the dessert, I started with dessert for lunch yesterday. It was a yummy, I was in Laclede Grove, so it was a yummy caramel apple pie. And I said, I'm going to have that first, right? And so I didn't even eat all my salad. But then today I was like, I'm going to do it. I got up and I did these squats, and now I can't get up the freaking stairs. So, some days you do the things that align with your goals of care, and other days you do not. And Karen is going to kindly, professionally, and clinically call you out and say, hey, this is what you said you want, but this is what you're actually doing in life. Let's talk about how we're going to match those to the behavior and what you want up. And is the behavior or what you want different because your family wants it to be different, right? What's your goal of care? But does your family want it to be different, and that's why you're being different? Well, let's figure out how we can bring all those pieces together, right? So definitely conversation should come with any sort of document, and put it in a way that your family can really understand what you mean, and don't be afraid to have those conversations. And if you are afraid to have those conversations, bring in somebody that can help you manage that conversation.
Doesn't hospice normally involve stopping something that you're doing for the patient?
Does
Some
hospice
medical care.
involve stopping medical care? Now, all hospice companies are different. And that's a huge thing to know. Some hospice companies might want to stop all of your medications and your care outside of comfort. With Lutheran Senior Services, we leave that to the discretion of the patients. As long as there's an argument that says you're within those last 6 months of life, as far as your regular medications go, you can continue those. But there's a caveat to that, is if you're on chemo or if you're on dialysis or anything like that, those really aggressive therapies that you would, when you're electing to enroll in hospice, you're also admitting the fact that, okay, I've done all these aggressive therapies. I'm done with that. I'm done with the needle sticks. I'm done with all that. So those kind of therapies and modalities would have to be, ceased But you can continue with like regular maintenance medications. Those would be billed through your insurance with the same copay that you would that you have now, in addition to the medications that hospice would give you if you're having anxiety, shortness of breath, pain, those kind of things.
Yeah. There's certain things that hospice covers under that benefit, like she just mentioned some of them, certain medications for pain, anxiety, comfort, whatever, that hospice covers under your Med-Aid benefit. But sometimes if you want to continue certain things that's not kind of covered under that benefit, then it would be billed to you separately, what you would normally pay for it if you weren't on hospice. So certain medications you would still pay for through your regular pharmacy, but there's a lot of things that hospice provides as part of that benefit. You know, there may be durable medical equipment, hospital bed, oxygen, and maybe like briefs, or like you said, pain medication, a number of services that are covered. And if you want something that's outside of that, then you might just be paying for it, and it's not under the hospice benefit.
Yes.
What about feeding tubes?
Feeding tubes
Is
with
that something that can be removed?
for palliative or hospice?
Palliative going into hospice?
Okay. With feeding tubes, that's kind of a, what's the actual for hospice for feeding tubes? Is it kind of?
You can continue on your feeding tube even when you're with hospice, but that the formula that goes into the tube may not be covered under hospice. Again, that may be something you still continue to pay for outside of hospice, but you're asking.
I'm not talking about payment, I'm talking about being able to
Discontinue.
remove a feeding tube.
Yes. Yes, I mean, that's something that can be done. If someone's done with tube feeds and they no longer want to accept those, that's absolutely something that can be done. Now, it depends on who it is, if it's their own personal decision to do that, or if it's someone that doesn't have the cognitive abilities to make those decisions, then it would be their power of attorney to decide to make that decision.
Or you could simply stop using the tube for nutrition and they just flush it. So maybe the procedure of removing the tube from your body would be a little bit too much, right? But you can still have the tube and they just flush it to keep it viable, but not actually use the nutritional formula that normally goes into it. Yes, ma'am?
What if it has been your source of nutrition for 50 years, 40 years, or 30 years, because you cannot take something orally?
So what if it's been your source of nutrition for 15 or 20 years because you're unable to orally take in any sort of nutrition?
Then that would be something that you would probably want to keep intact, so you can get any medications. Now, let's say if this person, if they're deciding to discontinue the tube feeds and this is what's primarily keeping them going, then that would definitely be a hospice scenario. And when hospice comes in and prescribes medications for comfort and anxiety and all of that, all the stuff that they do can be done like sublingually under the tongue, and it's not something that necessarily has to be swallowed. But the tube feed, or having a tube feeding, or the PEG tube, I'm sorry, makes it a lot easier to administer any other medications. But it would just, I mean, if the person decided that they're done with those aggressive, that tube feed therapy, then it would just be clamped and just used for medication administration purposes.
Anybody else have a question they want to ask?
I can give you an example because I know some of the previous in-services that we had asked for, like, well, I gave you all this information. Well, what can you do for me? Well, I had a gentleman, I went to his house, his wife wanted him on palliative care because he was kind of having some health complications from his diabetes. Well, from heart disease, but primarily caused by the diabetes, the uncontrolled diabetes. So I go into his house and he's like, I just don't think I need your service. And his wife says, sit down here, we're doing this, you're doing this. And so, like a good husband, he kind of lets her, he to appease her, he signs the paperwork and he goes on to palliative care. So as I'm looking, I have access to his medical records from his doctor's office, and I'm looking and I said, you know, your numbers for your blood sugar keep going up, and your doctor keeps increasing your medication, but I don't see that those numbers are coming down. So what's changed with your diet? I said, first, let me ask you this. Do you take your medicine? He said, you know what? You're the first person that's ever asked me that. No, I don't take my medicine. He said, my medication gives me diarrhea, so I only take it when I'm constipated. And so I said, well, you know, I said, did you ever tell your doctor this? He said, no, because I don't want her to be mad at me. You're the first person I've ever told this to. And I said, well, you know, for this one medication that you can't tolerate, there's 15 other ones. So we can change you very easily over to something that would, your body, you know, would be more agreeable with your body. And we got him changed over, and his A1C, the diabetic numbers, indicators came down with the treatment. And one day he told me, he said, you know what? I feel great. He said, I felt so horrible before when my blood sugars were that high, and I would have never done this if it weren't for you coming to see me, because I would have never had that conversation with my doctor. And they've got, you know, 20, 30 minutes to work with you. They've never asked me if I take my medicine. So he's like, I feel like $1 million now. So those are the kind of things that you don't realize that, you know, when I walked in, he didn't need any help with anything. So there's a lot of scenarios like that, very similar to that's what I'm here for, is if something's not working, you know, we're looking for another option, another treatment plan that's gonna work for you and minimize your side effects so that you have a better quality of life.
Yeah, definitely good point, Karen. And what I say is I feel like healthcare is, especially adding palliative care, is kind of healthcare starting to get it right, because that's already been the perfect example. You guys have been perfect students your whole life, right? If the doctor tells you to do something, you do it, or you don't, you just don't tell them, like good little girls and boys, right? And, you know, now we need to learn that it's okay to speak up, it's okay to advocate for our care, and we should understand our diseases and our illnesses, the symptoms, what to look for, what to expect, and we need to be asking those questions, and we need to be educated on that so that we can make proper decisions, figure out what our goal of care is, and make sure that we're getting the correct support to live the best quality of life that we have for where we are right now. And so palliative care is kind of that link that helps to sew all the pieces together. There's you and your family, and then specialist 1, and your primary care, and specialist 2. And not everybody is always kind of speaking or kind of watching out for certain things. I know we even talked about just changing medications because you've been on it for 30 years. But 30 years, it hasn't changed. 30 years ago, you were 170 pounds. And now you're 110 pounds. So maybe nobody's asked the question or thought about the fact that we need to decrease the dose. Maybe you need to stay on it, but maybe you don't need to be on that particular dose. Like those sort of things, and kind of asking those sort of questions and getting you to understand some things so then you can start asking the right questions, right? You don't know what you don't know. You don't know what questions to ask, but when you introduce somebody who starts asking those questions and asking you, what do you want? Then you're able to understand the type of questions you should be asking for yourself, right?
Just once a patient goes into hospice, does palliative care cease? Or do you continue into the care that the patient's receiving from the hospice people? You know, years ago it was like, okay, this person's dying, let's give them morphine. And then they'd go, oh, you can't give them any more than that, they're going to die. Well, they were dying. You know, you can't give them another CC. And it was like, what? So is there an intermediary there, an area
Yes.
there where palliative care is working with hospice in that moment?
Okay, that's a great question. So with palliative care, once we all agree on hospice, and if you're, you know, obviously I don't have those conversations until that is an appropriate treatment. Once we agree, I make a warm handoff. So I would bring in the hospice team. Now, I will say this with hospice, is hospice, if you thought you were getting good care with palliative, boy, you're in for a real treat, because hospice is awesome. Like, because you're going to have like a nurse checking on you twice a week. You're going to have a social worker who's, you know, pretty much like a licensed therapist that's going to come in and help talk to you or visit with you, however you want those visits to go. You're going to have the chaplain that's coming in and hold your hand or visit with you, or whatever you want to do during that time. And then you're going to have a home health aide that's going to come in, or a bath aide that's going to come in and give you a really good head-to-toe cleaning and make you feel like $1 million. So there's going to be so many members of that team that you won't even miss that much, the palliative care.
Karen, tell them how often your visits will be.
Oh, yes. So my visits are monthly if someone's doing pretty well. And then you can always, you have my number, my direct work cell. If you're having any problems or questions, you're always free to give me a call. And then my patients that have a lot more health complications, I try to see them like every 2 weeks or so.
Do you just work for Mason Pointe, or do you cover other rush?
I go to all 4 of the communities, to Breeze Park, Mason Pointe, Merrimack, and Laclede.
Do you have a team that works under you?
I don't directly, but if I have someone that has a lot of emotional turmoil in their life, our hospice chaplain and social worker are able to kind of help to with those palliative patients as well. If there's something that maybe some visits from them might be helpful, then we can get that set up. Yes?
I had something that always bothered me. When my husband was on hospice, of course they took away all the medications. And one of them was, it caused him to have a minor stroke.
Mm-hmm.
And so then, he couldn't hardly feed himself or any of that other. And I just wondered, why did they have to take that medication away?
Well, like I said, not all hospice companies are created equally. They all kind of work along different practices, and I can't really speak to that particularly, but I know like with our hospice, we allow people to stay on their medication. We give them the option. Do you want to stay on all your medicine, or do you just want the ones that you absolutely need? And kind of let you dictate that care as long as it makes sense, and it's nothing like let's say I have a patient that has stage 4 cancer, and he's still on some oral chemo medication. Well, he's not quite ready to give that up, so he wouldn't be eligible for hospice at this point, because it's a very expensive medication. And until he's kind of ceased that idea that maybe this medication would work, then he can continue on that with palliative care. And if he gets to the point that maybe he's realized, or he's gotten to the point where his symptoms are getting too severe and there's no cure in sight, then he would stop those that oral chemo and go on to hospice. So we do allow people, though, as long as it's not super aggressive treatment like that. If it's your regular blood thinners or aspirin or your blood pressure medication, all those things you can still remain in place.
Well, I don't know why it's so different, and this was with Missouri Baptist. So
How long ago was it?
5 years.
Yeah, I'm not sure. I can't really speak to that. I'm sorry to hear that, though, because that really makes things more complicated for his time. Yeah,
Yes.
I'm sorry to hear that.
Any other questions that we can answer? Do you feel like you understand palliative care a little bit better than when you walked in here? Yeah. Okay, good.
Are you saying we need palliative care, hospice, our primary doctor, and 24/7 caregiver? Is that what I'm reading?
I'm not saying that you need any of that. You actually look like you're doing pretty darn good. So yeah. So and they're all different. No, you would not use all of those simultaneously. There may be some that you would couple together, but some of them can't even be used all together, right? Because we're talking about insurance covering a lot of these services. So you can't have hospice and home health. You can't have...
Insurance. I just wanted to know, what do we need to take care of us? Bill.
Well, so the question is, what do we need to take care of us? Well, that is a really loaded question, but that's one thing I kind of come into and try to figure out. Are you able to care for yourself? Are your needs being met? Making recommendations for private duty, if that's the case, or for a higher level of care. Is that what you're asking, or am I?
Do you come in if we have private duty?
Yes.
Care also?
Yes. There's no, for palliative care, the only contraindication or the thing that would disqualify you from palliative care is hospice. So everything, all the other disciplines, I can order therapy for you, so I can be in there when there's therapy, even if I'm not the one that ordered it, if you're already receiving therapy services. I can be in there if you're seeing your primary care and your specialist. So all of those things can coexist. And according to insurance regulations, it's just the hospice piece that's kind of set aside. Yeah.
I just have to get my ducks in order, and I was getting confused.
Yeah, it's a lot to absorb. It really is. There's a lot of nuances to it. Yes.
But we only could have your care if our primary doctor recommends it.
Well, with the primary care doctor, a lot of them, I haven't had any doctors, primary cares, that have said, no, you cannot have palliative care. I just haven't seen it. Because they are beneficial. And there's times, and that's what I was actually going to say a few minutes ago, is there's times that I have some patients that live in independent living that have difficulty, like they've had a pretty significant decline in health, and they can't get to the doctor as easily anymore. So I'm kind of the only hands on deck for this patient, to where I'm the eyes and ears, I'm doing their treatment plan, and then emailing the primary care team to let them know what's going on with the patient, how they were the last visit, and so they're fully abreast of the patient's condition. But this patient probably is only going to be able to see the doctor maybe once a year, because it is so cumbersome to get out to the doctor. So the doctor is really... every now and then we have a doctor that maybe not as on board with palliative, but most of them are very, very pleased with palliative, and they welcome that added support.
And again, you can advocate for yourself. So you can say, if you feel like, palliative care could be a benefit to me, I think that I would like to sign up for their program, you can advocate for yourself and call the doctor and say, hey, I've heard about this palliative care, and I think that that'd be something that could be helpful to me or my loved one or whatever, and I would like for you to, write an order for it. And Lutheran Senior Services is, the company I want to use, unless you want to use, one of the other, Mercy or somebody else, you let them know who you want to care for you, but you can call your doctor yourself and let them know that you think you want to sign up for palliative care. Definitely, in order for us to get started, we need an order from your primary care doctor. And again, usually that doctor wants to hear from this patient that that's something they want, instead of hearing from us first, like we're soliciting or whatever. They want to hear from you that that's something that you want, and they would send the order over to us, and then you would hear from Karen to schedule a date to come out and do the initial consultation and review of symptoms and things. So that's how that works. Speaking of getting your ducks in a row, in the back there is, if nothing else, take the business card that's in the back, because it has all three of our main service lines, and you can reach your doctor can reach Karen in the palliative care program under the same number as hospice. That director is the same, and the medical director is the same for both programs. So you can call that same number that's under hospice in order to get palliative care referral over to Karen as well. But that card does have all three or four of our service lines numbers on there. Stick it in your wallet or your purse. So if you're ever at the doctor and he says you need home health or private duty or hospice or whatever, you can say, I would use Lutheran Senior Services, and here is their information. So you have that on your person when you do need to get your ducks in a row. Any other questions? No. Well, thank you. You guys have asked some really good questions. You've been a great audience. We were definitely happy to spend this time with you. And I do hear that soon after this is Taco Tuesday, so it's like a really good plan. I might join you on that. So, again, I'm Denise Travis. This is Karen Schroeder, and we appreciate your time.
Nice to meet you all. Have a great day.